Welcome to the June 2023 Talk with the Doc. I'm Casey Peluso from Parkinson Foundation, Western Pennsylvania. I know I'm joined by my one colleague, Lauren, and thank you, Dr. Leichliter, as always, for conducting this informative Talk with the Doc each month. I'll let you get started.
Well, welcome back, guys. Again, for those of you who know me, welcome back. Who've been here before, welcome back. If you haven't been here before, if this is your first time, welcome. I'm Dr. Leichliter. I'm a neurologist and a movement disorder specialist sitting here in my office at Allegheny General Hospital. And I'm going to answer your questions. So if you have questions, type them in the chat box. That's the best way to get them to me. I have a couple sent to my email, but I'll get to those first, and then I'll come back to the chat box. And so they can pile up there for a little bit. I'll scroll through them back to the top once I get through the ones in the email. A couple things that I always like to remind people are everything you hear is my opinion. I have a lot of opinions. I like to think they're the right opinions. That's why they're my opinions, but they are opinions nonetheless. And so if you do see a different neurologist or a different movement disorder specialist or a different doctor, or you have a cousin's friend who's in the medical field, they may have a different opinion. Them's the breaks. Since I'm the one with the microphone, you're going to hear my opinion. The other thing I like to tell people is that at the end of the day, this isn't a great place to get individualized care. So, telling me, I've had it this long, I'm on these medicines, this is my problem, what do you think we should do next? Not a great place for that. My answer is going to be, you should really talk to your doctor. And really a key here is communication with your doctor is important. The last thing I like to tell people is that generally the things that I tell you are as scientifically based as I can come up with, or as I know. Sometimes there's no scientific data to back up stuff that I talk about. And so at the end of the day, sometimes I do make stuff up. I feel like I've earned the right to do that. But if I am making stuff up completely, I will usually throw up some quotation marks and let you know that I am making stuff up. So take with it what you will. All right, let me get to the emails first, and then I will go over there and we'll get and then hopefully we get everybody out to the nice day that we're having, that I have no idea because I'm just looking out the window. All right. And actually I saw this just popped up in this chat as well. But nonetheless, question number one. We've talked about gut health and Parkinson's disease. Some Finnish researchers say, I don't know, some bug that I can't pronounce causes Parkinson's disease. This is out of the University of Helsinki. There's a certain strain of microorganism in the gut that seems to be potentially related to Parkinson's disease. And I say that because I looked it up and I read through their study. And what they ended up doing, and I thought this was actually an interesting study, although I'll raise the questions that I have for it to you in a second, is they took 10 patients that had Parkinson's disease and 10 of their significant others that presumably did not have Parkinson's disease, and they did stool samples. And then they basically tried to find this certain strain of microorganism in the stool samples of people with Parkinson's disease. They then fed this to worms, C. elegans, which is a commonly used worm in research. And they wanted to see what would happen. And what happened is the worms that ate the bugs that were theoretically associated with Parkinson's disease died early. And so they're now doing it in a mouse trial where they're doing something similar. They're really seeing, ultimately working it up to seeing, in higher models of Parkinsonism, does it still hold true? The reason why I bring that up is A, that's a really interesting study. B, what was interesting is I think 7 out of the Parkinson's patients had this microbe in their stool, but something like 5 or 6 of the non-Parkinson's patients also had it. So I didn't know what to make of that. Obviously, I've made fairly clear my opinion on animal models, cell models, things like that. While these are useful studies, I do not hang my hat on them to say this is the definitive answer. And so I think it's a bit of a stretch to say that this proves that this bug causes Parkinson's disease. I think that's a pretty big stretch. We know that gut and Parkinson's disease go hand in hand from a lot of different studies. There's been several studies where, they've compared the microbiome of people with Parkinson's disease to people without Parkinson's disease, and the microorganisms are significantly different. There was a study, I think, again, also out of Finland or one of the Scandinavian countries, where they looked at people who had what's called a vagotomy. So they cut the nerve that goes from the brain to the gut for whatever reason, not for this reason, but people who had had that done. And those people were much less likely to go on to develop Parkinson's disease, suggesting that perhaps, things start in the gut and work their way up the vagus nerve. There have been studies that have put correlation after correlation with, gut health, microbiome, different organisms and bugs with Parkinson's disease. But can we say that one causes the other? No, I don't think that has been proven yet, at least not proven to my satisfaction. Do I think there's more to look into this? Heck yeah. I mean, again, the gut is such a big thing in symptom with Parkinson's disease. I would say 80+% of my patients have some sort of constipation. It's such a big problem, and it's not just the large bowels or constipation. The small bowels don't work as well either. The stomach empties very slowly. Esophageal motility is affected. So the entire GI tract from top to bottom is impacted. And so we haven't quite, and we know there's tons of dopaminergic or dopamine nerves in the GI system, the enteric nervous system, which is the nervous system that controls the gut. And so there's a ton of evidence to suggest that there is a large connection between Parkinson's disease and the gut. We haven't unraveled it yet. And so at the end of the day, I'm interested in studies like this. I'm interested in research like this. I'm particularly interested if we can then extrapolate it to, hey, if we figure out a way, and they mentioned this in the study, if we test people for this and we find that it does correlate with causing Parkinson's disease, and we test people early and we somehow get rid of that strain, can we delay the onset? Can we slow down disease progression? Can we prevent Parkinson's disease? I mean, these were all the questions that were raised with that article that I looked at. And I think they're all really interesting ideas. They're really interesting things that we should definitely continue to research and to study. But that's about where it is for now. Again, there's more to come. Again, this group out of these countries have been working on this for a while. They've published a lot of good research. I think this was a good study too. And I think as we take it through the progression and we see what we can come up with, I think this is an area that we're going to be able to target, at least for some people. But it's just too soon to tell. And you guys know me. I don't get too excited. I don't get too excited to begin with, but I certainly don't get too excited too early, because we've been let down so many times in the past. And well, now I believe it if I see it kind of guy. But again, more to come. There's definitely a connection between the bowels and Parkinson's disease in the brain. And I think this was just another study that suggested that, and hopefully gives us more things that we can, kind of work towards or work on to really get to where we want to be, which is disease modification, really helping people do better longer. The second question that I got in this email was, I'm presently on Rotari 4 times a day. That's a different version of carbidopa levodopa. They exercise a ton, 4 out of 7 days. They're limiting junk food, decrease things that cause inflammation. And recently they experienced pain, muscle pain, particularly in the legs. And the question is, what's the best approach for that? Well, and again, pain's a tough one. Pain comes in so many different varieties and so many different causes that the answer to that question comes with a whole slew of more questions. What's it feel like? Is this a muscle cramping type pain? Is this a sharp shooting pain? Is this a burning electrical pain? Meaning, is it neuropathic? Does it correlate with the medicines? Does it kind of go off and on as you take your pills? It gets better. As your pills wear off, it gets worse. Does position change anything? Does activity change anything? The short answer is, when you're dealing with pain, there's tons of questions that really have to be looked into to figure out what to do about it, right? There's like 5 or 6 or 7 or 8, I lost count, different things that can cause pain in people with Parkinson's disease. All the way from the disease itself in the brain, to joint problems, to muscle problems, to wearing off of the medicines, to spine problems. And trying to sort through kind of where do we think it's coming from really helps decide, okay, this is the best way to try to work on it. If you have kind of musculoskeletal pain, I send you to physical therapy. If it's a wearing off pain, we need to adjust your medicines. If you have spinal stenosis, I need to get you to either a physical therapist or a surgeon. If you have central pain, well, then we have to tackle that a little bit differently. And so when it comes to pain, which is not an uncommon complaint or problem in Parkinson's disease, it really gets down to figuring out what type of pain you're dealing with, what we think is causing it or triggering it, in order to figure out what to do about it. And that's hard. And I know I said it like it's easy. That is not an easy thing to do by any means for you or for me. But the more information you can pay attention to, and believe me, you guys are very in tune with your bodies. You know a lot about what's going on. I only know what you tell me. And so if you're able to correlate, okay, every time I do this, or when I take my medicines, this is what happens, or this is what it feels like. This feels like my stiffness from Parkinson's disease, or no, this feels like burning pain that's shooting down my leg like I had sciatica before. These are the information that really help us figure out what test to do, what treatment to offer, what strategy to come up with. And that's the best way to try to work on it. It's not easy by any means, but the more information and more details you can kind of tease out, the better success we'll have. So this was must have been from one of my own patients, or maybe I talked about it last time. I can't remember. But it was. Thanks for muting me. I think I caught it though. Don't worry. Was a question about injections for drooling. So drooling, or sialorrhea, which is the really fancy term for it, is not an uncommon problem in Parkinson's disease. And it has a bunch of causes. We think, again, a lot of it is you tend to be flexed forward and your mouth hangs open, and well, gravity works. But also secretions tend to be a little bit more, they tend to thicken up. Drooling is not an uncommon situation or problem in my patients or in my world. And there's a variety of things you can do about it. So one thing is there's pills. We'll use things like glycopyrrolate or Robenol. We'll use scopolamine sometimes, amitriptyline, things that are known to have kind of drying of secretions as a side effect, really. And we try to use that side effect to our advantage. I don't know that I've had a tremendous amount of success with medications for drooling. Sometimes Robenol is helpful. But what I've had the best success with are injections. And so botulinum toxin injections, I've had pretty good success from a drooling standpoint. And a lot of times I will target both the parotid gland, which is the big gland in here, and the submandibular gland, which is a smaller gland under here. And there's a bunch of different varieties of botulinum toxin. It's not just Botox, which people know about. There's Dysport, there's Xeomin, there's Myoblock. My opinion, and again, I don't know if this is proven anywhere, but my opinion is that Myoblock tends to be the one that I go to the most because I've had the best success from a drying standpoint, but I've had success with Botox and Xeomin and things like that as well. And so those are the injections that I'm talking about when I talk about injections for drooling. Now, if you went to a textbook, opened up the book and said, oh, this is how you do the injections, you would not see what I do when you come to my office. When I initially learned from, I forget who I learned it from, it was kind of a couple of injections here and then one under here. I did that initially. My success was kind of iffy, maybe 50-50. And so I went to some sort of program. I think it was an Allergan program who makes Botox. Or anyway, I saw somebody who was doing more of a grid pattern over this. And so now I'll do about 8 injections here and one under here, which sounds like a whole lot of injections, and it is. But I've had much better success with that from a drooling standpoint, probably because everybody's anatomy is a little bit different. And when you only do 2 shots into here, you're much more likely to miss. I could be wrong about that. That's just the way I do it. You may go down to the next person and they do something completely different. That's just my opinion. But I think the injections in my world have been more successful than the pills. Again, they do hurt. Nobody's ever said, wow, that felt great for jamming a needle into my face. But the pain seems to be temporary and it does seem to help. So again, if it is something that, drooling is a problem and it's really bothering you, again, communication with your doctor is key to success, to really come up with what's the best strategy for how to work on it. Because that does impact quality of life. That really does keep people from doing things, wanting to go out, going out to eat. And so again, just because you may think, oh, well, I don't like it, but it's not a big deal, I'm not going to tell my doctor, that's not a good plan. If there is something that's impacting your quality of life, your day-to-day life bothering you, you should bring it up. More than likely, there's something we can do about it, or at least try. All right, couple more. One more. Not too many emailed questions today, which is okay. Maybe everybody's outside enjoying the sunshine. All right, so my husband and I will be seeing a movement disorder specialist for the first time. I won't say where, it tells me, at the end of August. We've waited a long time for this appointment, which is not all that surprising. Any of my patients know just how long it is and how hard it is to get in to see me. We've only seen neurologists more locally. What should we expect at the first visit? We were sent a very lengthy questionnaire. What tests should they want to perform? We're hoping that they're going to get some better symptom control, blah, 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 blah. And I thought this was a really interesting question because A, I don't think anybody's ever asked it before, but B, I like to tell you guys what to expect, what you should do to prepare, things like that. Because again, it takes forever to see us. I had one of my patients move down to, I don't know, I want to say North Carolina, maybe it was Georgia, and it was going to take them over a year to get in with a movement disorder specialist. And so this is not just a me problem or an us problem or a Pittsburgh problem. This is an everywhere problem. And so it takes a long time to get in with a movement disorder specialist. And so you don't want to get there and be unprepared and, have to wait another 6 months or whatever to get back in so that you can actually ask the questions that you want. I know a lot of providers send out questionnaires. I think if you come see me, you have to do a couple of questionnaires. I'm not a huge fan of the questionnaires, but they don't ask my opinion on this one. They make me do it. I look at them sometimes, but whatever. But a lot of people really do give you questionnaires specifically for Parkinson's disease or specifically for whatever you're coming in for. And they do give a lot of information. And so you should fill them out. And then you should go prepared. And so what I mean by prepared is I don't expect you, I won't say we, I won't generalize. I don't expect you to come in and basically like dictate my note for me, right? I recognize that patients don't know what I'm looking for, what I'm asking for. They're not going to give me information in the exact order that I want it in, that I eventually put it into my note. And it's my job to make sure I get all the information. But as organized as you are, the better off you're going to be. So the key things that they're going to want to know, which is what I would want to know, is, when did it start? What were your symptoms? Who made the diagnosis? How has the progression been? What kind of medicines are you on? What kind of medicines have you tried that you're not still on? Do you have any problems with the medications? Is there any family history? Do you have any of the non-motor symptoms like loss of sense of smell, talking in your sleep, constipation? These are going to be all the questions that I would ask you. And so if you have these kind of outlined already, it's easier. Particularly people come in and I say, oh, how long has this been going on for? It's hard to remember. Again, I don't remember last week, let alone last year or 5 years ago or 6 years ago, whenever the diagnosis was made. So start thinking about these things now, because we're going to want kind of a story. What I like to hear, what I like to end up doing in my note is I write a story. I say, this is Mr. So-and-so. He's a 65-year-old male with a past medical history of high blood pressure, high cholesterol, diabetes, whatever, who comes to me for a second opinion, for another evaluation for Parkinsonism. His symptoms started 6 years ago. He was first diagnosed by this doctor 5 years ago based on these symptoms. He was started on this medicine. This was the end result. This is how it's progressed. This is what we've tried. So if you ever, and again, my patients have access to all their notes. If you go look at my note, that's pretty much how it's outlined. And so the more of a timeline, the more information you have outlined, the better off you're going to be. The other thing that's really important, again, is the medicines. And so we really want to know, what are you on and what have you already tried? Because if you come to me and right now you're only on Cinemet, but you neglect to mention to me that, oh, you've also tried Requip, Mirapex, Nupro, Azalex, Selegiline, and Norians, I'm going to probably put you on those medicines again. And so at the end of the day, we don't want to necessarily do the same thing that's already happened. We'd like to do better than what's already happened. And if something hasn't worked, it's good to know. So as many of the things that you can remember, again, depending on how long this has been going on for, as many of the things that you've tried that you can remember, and specifically if you remember what happened. If you tell me that Mirapex made you go gamble away your life savings, I'm going to be less likely to want to put you on Requip or the Nupro patch, because they're in the same class of medicine. But if you come in and tell me that you were on Mirapex and it made your stomach a little upset, well, then I might go to that class of medicine. And so if you can remember what medicines you've been on and you can remember what happened on those medicines, it's really going to help us decide what to do next. And then really, I think kind of the next most important thing is, what are your questions? I can't tell you how many times people come to my office and I say, all right, this is what we're going to do. Any questions about that? And they say, I had a whole list of questions, but I forgot it. And now I can't remember any of them. I say, well, that stinks. I don't know how to help that. And so again, if there are specific questions that you have that you really want an answer for, and these are the things that you say, I don't want to leave the office without getting the answer to this, this, and this, you should really write this, this, and this down and bring it with you. Because we're not mind readers. I'm not entirely sure what questions are important to you or what you really want to know. I don't know how much Dr. Google searching you've done and you've read online and you're coming to me with stuff that I'm not aware of. I don't know that you haven't done any reading and you know absolutely nothing about Parkinson's disease, and I need to explain it a little bit better. All of the above happen. And so really to get the most out of your appointment with your movement disorder specialist, because again, we're hard to find and we're hard to get into, being prepared is helpful. So know your story, know the medicines you're on and what you've tried before if you can, and really come prepared with whatever questions you really want an answer to. Again, if you don't have any questions that you're like, this is really important that I get an answer to, then it's not that big of a deal. But the last thing I want you to do is come in, we go through the appointment, we do everything, we're done. You go home and you're like, he didn't answer this for me. I'm like, well, you didn't ask that. So how am I supposed to know? So again, the more prepared you are, the better off you're going to be with your visit, and try to utilize your time well, because at the end of the day, you get a short amount of time with us. To try to pack all of that into one appointment, it's not easy. And so as prepared as you can be, the better off you're going to be. I think that covers it enough. All right. And that was all the questions I had in my email. So let's scroll back up here to the top and start answering some of these. Please address restless leg syndrome symptoms in relation to Parkinson's. So restless legs can be a part of Parkinson's disease. It can be a standalone condition. I take care of patients who have just restless leg syndrome and not Parkinson's disease. But at the end of the day, it's also a part of Parkinson's disease, not uncommonly. And there's actually a couple different sleep disorders. So one is restless leg syndrome. And this is typically, I'm sitting there, I'm relaxing, particularly in the evening, and my legs just feel like they need to go crazy. I got to get up. I got to walk around. I got to move. That's the only way they feel better. It's an irritation. It's a burning. It's a pain. It's a discomfort. I've heard it described infinity different ways. But it's a bother, and it's made better by getting up and walking around, and then it gets better for a while, and then you sit down and relax again, and it comes back. That's the typical story for restless legs. This is different than, say, periodic limb movement of sleep, which is usually patient comes in and wife or husband is the one that says when he falls asleep, he just keeps moving around, and it really irritates me. It's similar and it's treated very similar, but actually a different condition than restless leg syndrome. And then there's REM behavior sleep disorder, which is very common in Parkinson's disease, which is actually acting out dreams, yelling, kicking, fighting, punching people, throwing themselves out of bed. That's an even different problem, and that has a whole different solution to it. And so there are these different sleep problems that come along with Parkinsonism, and restless legs is one of them. There are medicines that we use. So one thing you will also find is that iron is particularly important in restless leg syndrome. So you may wonder, why is he checking my iron studies when all I did was come in with this restless leg? It's because if your iron stores are low, all the medicine in the world doesn't usually work for restless legs. There's plenty of medicines that we use, and usually we can find something. Some of them are the Parkinson's disease medicines, like Mirapex is one of the better restless legs medicines. It's also a good Parkinson's disease medicine. But then there's other medicines like Horizon that's not a Parkinson's disease medicine, that's a pretty good restless legs medicine. And so there's some overlap there in terms of treatment, but at the end of the day, not always. And again, the key to success is bringing it up to your doctor, making sure they're aware, and making sure that they understand how much it's impacting your day-to-day life, how much is it keeping you from sleeping. That really tells us how aggressive we need to be. Things to keep in mind when you're at your next office visit, but the two do go together quite frequently. I feel like this is like a setup question. How beneficial is exercise for combating Parkinson's? I could give in fact, I have given entire hour talks on exercise of Parkinson's disease, but I won't bore you with all of that. But the short answer is it's super and ridiculously important and beneficial. Exercise is my absolute favorite topic, for those of you who don't know. And there's one really important reason for that. And it really comes down to what the medicines don't do. So we have a lot of drugs for Parkinsonism and Parkinson's disease. You can't see my board, I have two whiteboards in my office. One's over here. It has about 15 medicines for Parkinson's disease listed on it right now. I was teaching my new nurse. I have a lot of medicines for Parkinson's disease, and they all really, really do help, and they treat different symptoms, and they help people feel better, and they help people move better. But there is one really important thing that they do not do. They do not slow down your disease progression. They do not keep you better longer. They do not alter the course. They are not disease modifying. And while I can't say that exercise is disease modifying for sure, at least not yet, I believe that it is. That's my opinion. I do think it's been shown to delay the onset in people who are predisposed to have Parkinson's disease. I think there was a study that showed that. But at the end of the day, I really do think exercise is disease modifying. I don't know why it's disease modifying. I don't know if it's just because it strengthens up your muscles or bone health, or it helps balance, or it corrects posture, or it corrects mitochondrial dysfunction, which we know is big, or it works on inflammation, or it just is an antioxidant. I don't know why it works. I don't care why it works. It does. In my opinion, it really is disease modifying. And really, I'll just tell you my own experience. Patients tend to fall into one of three categories. Patients who come to me who have exercised their whole life. These are gym rats. They've done a great job, but they were dealt bad cards. That's how they ended up getting Parkinson's disease. But they've done a tremendous job of exercise. They continue to exercise. They go to the gym all the time. They're up, walking, running, dancing, biking, you name it. They do the best. 10 times out of 10, that patient does the best, regardless of what kind of medicines I use, what kind of symptoms they have. Those patients always do the best. Then there's the second group of people, and they're the people who are probably the vast majority of my patients who come to me and maybe exercise a little bit, but definitely not in the gym rat category. And then I talk to them about the importance of exercise, and they really get on board, and they get to the gym, and they do the exercise classes, and they go to the boxing classes, and they do Tai Chi and yoga and all the things. And 10 times out of 10, they come back and say, you know what, I feel better when I exercise. And I say, well, no kidding, you do. That's why I talk about it so much. Those people do the next best. And then the last group is that no matter how many times I talk about exercise, and for whatever reason, sometimes it's up to the patient, sometimes it's out of their control. They don't have motivation, or they have a structural problem, they have back problems, they have inability to do it, but for whatever reason, I just can't convince them to try to be more active in exercise, and they do the worst. That's been my experience for the past 9 to 10 years, and I think that's going to be my experience for the next 9 to 10 years. And so can I say that that means exercise is disease modifying? No, I haven't proven that with my pseudo observational study. But in my opinion, I really do think it is. And so that really is why it's the most beneficial thing you can do, in my opinion. So get up, get out, get active, get moving. Keys to success. So this is actually interesting. So, and this was really a thanks to the Parkinson's Foundation of Western Pennsylvania for arranging the showing of the Michael J. Fox movie, which I still haven't seen. But why I say that's interesting is I actually had a patient who came back who was like, that was the worst idea. Going to see that movie was the worst idea I ever had. It didn't make me feel good about it, and it doesn't make me feel good about what's going on. And so again, I think that's a double-edged sword there. But I think for the most part, I've heard good things about the movie, but you just have to kind of be careful about what you're reading, what you're watching, what kind of information you're getting. The same thing is true for support groups. I think support groups do a great job. I think they really do a great job of getting information out there. But I have run into patients who say, I refuse to go to a support group. I don't want to see patients that are worse than me and tell me what I potentially have to look forward to. And I get angry at the people that are better than me. And so I've had patients tell me that. And so you have to take these things, with a grain of salt, do what makes the most sense for you. But if you're somebody who's inspired by things like that, or that type of information really makes you feel good and helpful, go watch the movie. I think, I haven't seen it yet. It's on my list of things to do as soon as I get some spare time. But I have heard good things about it. That was the finished study linking Parkinson's to gut bacteria, which is what I think I covered. Again, I'm still interested to see what else we can come up with, but that's an interesting avenue for potential treatment options, which is what I'm most interested in. What's the best recommended exercise for Parkinson's? Well, this has a real answer and then my opinion answer. The best exercise for Parkinson's is the one you will do. I know that sounds dumb. and a cop out. But it is. If I sit here and tell you that swimming is the absolute best exercise for people with Parkinson's disease, but you're afraid of the water, that ain't helpful. You're never going to do it, right? And so that's not a useful statement, because in your case, that's not the best exercise because you won't do it. And so the key to success in exercise is doing a lot of it and being consistent with it. When I say doing a lot of it, you really have to put in the work. The studies that really give you the minimum, and the CDC guidelines, are 150 minutes a week of exercise to get your heart rate up. That's a half hour a day, 5 days a week. That is not an insignificant amount of exercise. That is more exercise, in my opinion, than most people in the country do. And that's the minimum. There is no maximum. And so you really have to do a lot of it, and you have to be consistent. It can't be something, well, you do it for 2 weeks and then you take 2 months off, and then you come back and do it for a week because you're coming to my office and I'm going to ask about it, which I see all the time. And then you give up on it for the winter. Or I only do it when the weather is nice. Well, spoiler alert, we live in Pittsburgh where the weather's only nice 3 months out of the year and it's iffy the rest. And so you can't use the weather as a reason to not exercise. But the key to success is doing a lot of it and being consistent with it. And if you hate a specific exercise, you're never going to do a lot of it and you're never going to be consistent with it. If you can find something you like or you enjoy or it doesn't feel like work, you'll be much more likely to do it. And you'll be much more likely to do a lot of it, and you'll be much more likely to stick with it. I have a lot of people that go to the boxing class. Do I think boxing is the magic exercise for Parkinson's disease? No. Do I think it's good exercise? Yep. Do I think the boxing class is double as a support group? Yep. Do I think boxing maybe works on balance a little bit more than, say, something non-upright does? Probably. But is there anything magical about it? No. But a lot of people like going, and that's really where the benefit is. I don't think there's one best recommended exercise for Parkinson's disease. Find something you like to do a lot of it. Now, I do have a personal opinion on this one. I have opinions on everything, as I mentioned. My personal opinion is that there's a bunch of different types of exercise, right? There's cardiovascular exercise that really gets your blood pumping, running, biking, swimming, dancing. There's strength training or resistance training exercises that really builds more muscle and tones muscle. And then there's balance training, things like Tai Chi and yoga, balance therapy, things like that maybe aren't as strenuous as the cardio exercises, maybe aren't as muscle building as resistance training, but still work on the balance mechanisms. I personally think a combination of all of them are the best. Dabbling in a little bit of all of these, doing a lot of all of these things is really the best, because I think if you can get your heart rate up and we can build some muscle and we can work on walking and balance, those are really the things that I think help you do the best, the longest. And so that would be my personal opinion. I made that up. I don't think there's data to support that, but I think it's logical and I think it makes sense. And I think if you're able to do it, you can really see the benefits to it. Sorry, this is a long one. It takes me time to read. All right, so I happen to have horrific balance, static balance, pretty moderate thoracic scoliosis. What about PT, which has been ineffective, and surgery, which is maybe for pain, but difficult for balance? This is an aerial double whammy with PD as it affects game balance. Yeah, exactly. And so the hard part about your situation is everything that you have is multifactorial. Parkinson's disease is going to affect your balance. Pain is going to affect your balance. Scoliosis and spine problems are going to affect your balance. And that is not going to have an easy solution. Therapy, even though it's been ineffective, is still probably the most proven thing for walking in balance, more so than medications have. There's some medicines that I use for walking in balance, but there is very little data, very little good data to suggest that they help. I still try them because I feel like we got to do something. And because walking in balance is so dangerous, falling is the number one way my patients end up in the hospital. It's such an important thing that we work on that we really have to try, even though I know the data is limited. Again, physical therapy and exercise, unfortunately, are the mainstays of treatment. And I know they don't feel like they're all that effective because you do them and maybe you're not gaining ground, but maybe you're not losing ground either. It's probably going to be a combination of kind of therapy, exercise, medicine. I hope not, but maybe surgery, pain control. So it's not uncommon for me to send my patients to a pain specialist. Sometimes injections work, sometimes nerve ablations work. Again, it's really a group effort here. And as I like to tell, not just you guys, but every patient who asks, Parkinson's disease is not a one-man show. I am not it. This is not a, oh, you come to me and I fix everything kind of thing. In fact, you guys know this, I don't fix anything. I manage a whole lot of things, but it is very, very common for me to refer patients to other people, even though I am well aware that it is Parkinson's disease oftentimes as the underlying cause. I send patients to urology, gastroenterology, psychiatry, pain management, neurosurgery. It becomes a group effort. You really do have to have a team: physical therapy, speech therapy, occupational therapy, sometimes nutrition and dietary, sometimes social worker, case management, things like that. This really is a team effort. And in a case like that, where you have all of these different things that are impacting all of your symptoms, it's going to take a village to kind of work on that. And so that's where you got to get started. That's not an easy fix for any of those problems, though. What are the dangerous or worse, the long-term side effects of Parkinson's disease meds on the gut, liver, other organs, so on? 20 years, 30 years, 40 years, what have I seen? I don't, and this is my opinion, I'd have to go back and look this up, but I don't think that I have seen, at least not with the drugs that are typically used and approved, any major organ damage. Again, they do get passed through the liver, they're filtered through the kidneys, but I don't know of, let me look at my list here. I don't know of a lot of kind of long-term organ damage from any of the medicines that we have. Duopa was suggested to cause neuropathy. So carbidopa, levodopa can probably cause neuropathy. That's not proven. They all have various side effects, but in terms of liver damage, or organ damage, kidney disease, liver disease, gut disease, I don't know that I've really seen it. There was a COMT inhibitor, tolcapone, that's not approved in this country that can potentially affect the liver, I think. But the ones that are approved in this country, so entacapone, opicapone, I don't think they carry the same warning. So I don't know. That's a very good question, and I'd have to look up all the drugs. Again, I can't think of anything that I've seen offhand or anybody that I've seen recently, or really even the remote, who came to me and said, hey, I was on this drug for the past 10 years and now I have liver failure, or now I'm on dialysis, or now, my gut doesn't work. The hard part is a lot of those organs are impacted by the disease itself. So that would be a hard thing to kind of tease out. But I'm actually not aware of any major long-term organ damaging side effects to the medications. If I find some, or if I look it up and I find some, I'll let you know. But that's been my experience. I am not going to the World Parkinson's Conference in July. I'm not actually going to any conferences this year. The Movement Disorder Conference is in Denmark, I think. I'll probably do some more online learning for that, because they always put it online afterwards. And so I'll listen to a lot of the lectures online. Same thing is true for the World Parkinson's Conference and a lot of these different conferences. A lot of the information ends up online, virtually. And so I'll probably learn some through that, but I'm not actually attending any conferences in person this year. Next year, I think the Movement Disorder Conference is in Philadelphia, so I'll probably go to that one, but too soon to tell. There's a long question. Sorry for the awkward pause. So long story short, and I'm going to paraphrase, was diagnosed with Parkinson's disease, took forever to get in with a movement disorder specialist. Again, not too surprising. A lot of the non-motor symptoms of Parkinson's disease, also has, we'll just say, cervical spine disease. had surgery. Doctor noticed something called a Babinski reflex. And they question, does that mean something? Things like ALS come up when you start Googling things. That's how you run into bad, dark areas if you start Googling things, and usually it ends up with you dying a horrible death. So you got to be careful where you go looking for information. So Babinski reflex, just as an aside, I think that's the long and short of the question, is what is a Babinski reflex, which is an interesting question. Maybe one a little bit off topic, but it never hurts. Same thing is true for a Hoffman's reflex. So if you read enough of my notes or your doctor's notes, or if you listen to us talk, you're going to hear things that sound odd, sound bad, sound fancy, sound smart sometimes. And you might say, what the heck does this stuff mean? So the long and short about a Babinski reflex. So a Babinski reflex is a primitive reflex. So if I take my reflex hammer, or sometimes even my thumb, and I stroke it up the outside of the bottom of your foot and go across your toes, the typical response is for your toes to curl. A Babinski reflex, which would be a positive reflex or a positive response, would be instead of your toes curling, they go up and they spread out. This is usually what's called an upper motor neuron reflex, or upper motor neuron sign. And so this is similar to a hyper reflex. So if I just barely touch your knee reflex and it jerks out, or your legs cross, or if I flick your middle finger and your thumb darts in like that, that's called a Hoffman's reflex. These are signs of something above the peripheral nerves malfunctioning. And so the hard part for that is you will find that those are positive in things like ALS, but they're also positive in other things. So don't get worked up too quickly, because if you have a neck problem or a cervical spine problem, it can give you positive reflexes. And so again, what I like to tell my patients is look, it's my job to look for all these things and put it together for you. It is not your job to look and see what I do and then try to answer the question for me. Again, not that Google is a problem. I don't mind when my patients look stuff up, as long as you're not scaring yourself with things like this. At the end of the day, research away. Believe me, you guys have brought to me more information than I've probably brought to you, which reminds me, I got to come back to the cognitive training. Remind me of that one. I did actually watch that video. You guys bring a lot of information to me, just as well as I bring information to you. So I do want you to keep staying up to date, staying informed, read. But there is a fine line. If you're going on and you're finding out that, oh my goodness, my symptoms tell me I'm going to die, that's not a great use of your time. If you go on and find that, you're learning all this bad information and now it's scaring you and you're afraid of what's going to happen, that's not helpful. It's not healthy. So go to good websites, do good reading, and use your information wisely. But so in this case, again, it's a positive reflex, which means there is some pathology somewhere, but it doesn't just relate or come back to one thing. It could be a spine problem, it could be a brain problem, it could be an ALS. I don't know. This would require a lot of work, more physical examination, more testing to see what we can come up with. But so when you hear us say things, if you don't understand, if you hear me say something and you're my patient, you don't understand it, ask me about it. I will absolutely explain it. But if you hear us say something, or you read something and you have a question about it, don't get overly worked up. I would much rather you ask me to explain it. That way we're all on the same page, and then you don't have to go search it on yourself for Google and find out that you're going to die. No. So the question is, do you think DBS is disease modifying? And my short answer is no. Yes, it often does, especially when you target the subthalamic nucleus, allow you to take less medicine. But as far as I know, the studies that have been done have suggested that it is still just symptom control. Now, again, not that that's a problem. I don't want you to I don't want the take-home message to be like, oh, well, that's just symptom control. It's not disease modification. That's crap. That is not the message. Symptom control is really important for patients to feel better, to get up and do what I want them to do, which is exercise, to be active, to do the things they want to do. Symptom control is super important for people feeling better. but it's not disease. It doesn't slow down the disease. It does not keep you better longer. The disease still progresses at the same rate, regardless if you do DBS or not. At least that's what I think the studies show. The same thing is true for all the medicines that we have. Is DBS a good choice? Yeah, for a certain population of people, it's a great idea. It is the best choice. It does usually allow us to cut back your medicines, although that's not my main goal. My main goal is getting you doing better. And usually you do need medication and stimulation to achieve that goal. And it has a good role in use in Parkinson's disease. But the short answer is no. Even though it does allow us to cut back medicines, I'm still not convinced. In fact, I'm fairly convinced that it's not disease modifying. Fair enough. You're going to have to tell me what stroll is. Casey, you mentioned it in the June newsletter. I'm not sure what stroll is. A virtual reality patient? Or
yes,
PT?
I don't know. I don't know that much about it yet. But let me
all right, I'll add it to the list of things I look up. I'll get back to you on that one next time.
Augmented reality, and you can use it in therapy in particular.
So I will tell you that, and again, nobody on this call is going to be excited to hear me say this. Technology is the wave of the future. I mean, I'm not a big fan of it myself, but I use it because it is coming and it is not going away. In the Parkinson's disease world, you're going to see more virtual things. You're going to see more online visits. You're going to see more wearable devices that directly relay information to your doctors. You're going to see the use of augmented or virtual reality in rehabilitation, in walking and balance training, in symptom control. There's all kinds of new technology that's happening in the deep brain stimulator world in terms of imaging and seeing where leads are. I'm only going to briefly mention and then quickly run away from the use of artificial intelligence for things in the medical field, which we're only seeing more and more of, particularly in things like pathology, radiology. I don't want to be the bearer of bad news for everybody because, again, I'm getting up there too, and I'm not a big fan of change or technology either, but it is coming and it is not going away, and you are only going to see more and more of this used. I'll check out Stroll and see what I think about it, but at the end of the day, my guess is it's some form of technology that's really helping people do a little bit better. And you're going to see more and more of that. How much daily protein should you have if you were on levodopa? Well, then the amount of daily protein you should have actually doesn't impact or doesn't matter based on the medicine you're on. However much protein you need to maintain your body mass, to maintain your musculature, stay out of malnutrition is going to be true no matter what medicine we have you on. The thing about protein and levodopa is it interacts. And so that's where you have to be a little bit careful. So the absorption of the levodopa is impacted by protein. So the carrier protein that helps you absorb or kind of take in the levodopa, get it to where it needs to be, is also the carrier protein or carrier transporter for protein. And so there's competition. And so I always liken it to a train. If you only have a few cars on your train, there's going to be a whole bunch of competition for those cars to get through the tunnel. If you got an infinitely long train, then you can eat as much protein as you want. There's plenty of cars to get through. And that's really a genetic thing. And so the protein and the levodopa issue really comes into trying to, in people who are protein sensitive, schedule their pills around eating, which is not always an easy thing to do. And again, some people don't notice. They can take their pills with food. They can eat a steak and their pills still work. Some people sniff peanut butter and they take their medicine and it doesn't work at all. And you really don't know until you try it, but there is a potential interaction there. But how much daily protein you need, I don't think it is dependent on your medication. That's an interesting question. Can orthostatic hypotension cause nausea? Probably. And why I say probably is, so let me take a step back. What is orthostatic hypotension? Well, orthostatic hypotension is a pretty common problem in my world. It's when you stand up, your blood pressure goes down because the receptors don't kick in that are supposed to fight that, and you get lightheaded, dizzy, and potentially pass out. So generally you have receptors in here that when you stand up, it makes your blood pressure stay the same or go higher, your heartbeat faster. So you keep pumping blood to your brain, which is important. But in people with Parkinson's disease and Parkinsonism, those receptors don't work. They stand up, the blood goes to their legs. They don't correct and pump harder to get blood up to their brain. And that's what makes you lightheaded. I would imagine that, nausea being an autonomic symptom, particularly coming from the vagus nerve, which is the nerve that kind of controls a lot of this stuff. I don't know this for a fact, and I'm making this up a little bit based on logic and based on a little bit of extrapolation, but I think the short answer is, yeah, I do think orthostatic hypotension and nausea could go hand in hand. Do I think one causes the other? Maybe, but I think more likely they're coming from the same process, and so they may just go together. But I could be wrong about that. But my short answer is probably. Is there any understanding of causal factors for legs, feet cramping with ankles locked so that the foot is angling in slightly and you can't pull the toes up to stop the cramp? The ankle foot are too rigid. Well, yeah, you just perfectly described dystonic posturing to a T. Foot goes down, usually goes in, toes usually curl, hurts like heck. Is there an understanding of the cause of that? Well, the cause is multifactorial. So dystonia can be a standalone condition. It can definitely be a part of Parkinson's disease. We think it comes back to abnormal brain circuitry. So more than a peripheral problem, it's a brain problem. But really, again, the key to trying to figure out what to do about this is seeing, does it time with your medicines? Is there any time of day, any relationship to your medicines that we can alter or address? Or sometimes what I'll do is, Botox injections to try to weaken those muscles so that it doesn't cramp as hard. Not easy necessarily, not ideal, but there are different strategies you can work on. But the short answer is you just described dystonic posturing to a T. It's probably a part of your Parkinsonism, and we just have to learn a little bit more about it in terms of relationships to see the best way to work on it. All right, I'll get to Stroll in a minute. Next time. Nope. And I agree with you. The next person, being proactive in your condition is always a good idea. Just don't be so proactive that you're reading things that are scaring you or doing you more harm than good. Believe me, I like it when patients bring me new information, things to look at. Stroll, again, case in point, I'm going to look it up and I'm going to learn something new. And this is good for me because this is how I then relay it to other patients where it could be potentially helpful. Have I seen about the small bar device from England worn over? Oh, I lost it. Worn over one ear that ends just with insight. It totally stops tremor and loss of balance. I find that really hard to believe because if there was anything that absolutely stopped loss of balance, every single patient would have it. But B, is that what it's called? The eye guide? What I wonder is not only that, I know there's also the Q, which I haven't heard about recently. There are wearable and I'll have to look that one up too. I haven't heard that one yet, but I'll look at it. There are wearable devices that cue you, hence the name the Q, which is a vibrating thing that people put on their chest. I wonder if this is something similar. I wonder if there's a cueing mechanism that more or less attunes you to what's going on. So again, and I would say 80% of people on this call can absolutely stop their tremor if they simply make a fist or think about it or move their hand. Likewise, every single one of my patients can do better with balance if they think about it, right? If you are aware and say left, right, 1, 2, you will walk better. Now, we don't walk around doing that. And as soon as you stop thinking about it and stop paying attention to it and forget about it, it comes right back. But this is where what I think wearable devices or cueing devices can really help with. It's not necessarily the vibration or whatever this thing is that's fixing the problem, but if it's alerting you to what's going on, allowing you to focus on it and pay attention to it, it gives you more power and more control over it. So again, I haven't heard necessarily about that one specifically. Probably the frustration I'm going to have is every time something good happens in Europe, it either takes forever or never actually gets here and I can never play with it or get my hands on it. That's been true for a whole lot of devices. I don't know what kind of guidelines or regulations they have in Europe, but man, we seem to have a whole bunch more. because things happen and pop out in Europe that just never get over here. But again, these are things that I'm interested in because I would much rather have you wear something in your ear or put something on your chest or a wrist device or something as opposed to giving you another pill. And so if there's anything that can help, I'm not against using all of it or any of it because, again, we do have limitations to the medicines and surgeries and things like that. So anytime there's another device or something that comes out, again, coming back to those wearable gloves that we all talked about a month ago that we haven't heard about since. Again, anytime you hear about these things, I'm interested. And believe me, as soon as I can get my hands on these things, play with them a little bit, try them in patients, I will absolutely be telling you about them. All right. That was the last question on there. So I'm going to end with one thing. So stop sending me questions because this is coming back to what we talked about last time. It was probably Donna that sent me this. I'm pretty sure it was. And so at the end of the day, what group was it? Who were these people who put on the presentation?
PMD Alliance.
Thank you. They basically, because I had made the comment last time that there wasn't any good data in brain games. So we're coming back to cognition in Parkinson's disease or cognition in general. In my experience or my understanding of brain games, Sudoku, crossword puzzles, word searches, there's not very good data to support their use. And so sure enough, the PMD Alliance put on a video about all of this stuff. And sure enough, I looked up a lot of their stuff. There is one area of cognitive training that they do have some pretty good data to suggest it is, and it's basically speed of processing training. This isn't just doing word searches. This isn't really just kind of thinking, even learning another language, which I think is helpful and I'm doing on my own too, because I think it's fun. Haven't really shown to be all that beneficial or have the data to support their use from a cognitive standpoint. But there were actually several studies that they cited, and I looked up and had actually decent evidence for this speed of processing. Now, the hard part is finding, cognitive training or something that specifically does that. And of course, I think it was Brain IQ or something that they talked about that, eventually does cost some money. That is really what they looked at or what they used to show that it helped. There may be other ways out there to do kind of speed of processing, but if you think about what speed of processing is, it's decision making. It's interpreting things coming in, processing it in your brain, and reacting to it. That's a really helpful thing. I mean, that's helpful for driving. That's how we do it. That's helpful for walking and not falling, right? And so it's not actually, when I think more about it or when I looked into this, it actually wasn't all that surprising that this type of training did have some benefit. Do I recommend it to people? I don't know. I still don't know enough about it. I haven't learned enough about it myself. Again, this is another thing that I have to kind of continually learn about and look into. But I can no longer say that there's not good data out there to support any of these things because they actually did have pretty compelling and pretty good studies that really suggested that this processing speed is important for future cognition. And they really were showing that it slowed down cognitive decline. Which again, we all hope for and we all aim for. And so maybe it is worth pursuing or worth looking into a little bit further. But I wanted to follow up on that because I did watch their video and I did look at what they were talking about. And I did go back to the studies that they were citing. And again, it's better evidence than I was expecting to find. And so I will no longer tell people that there's no data out there to support brain games or cognitive training, but there is data to support really a specific focus type of cognitive brain training. And I think the more you think about it and the more you look into it, the more sense it does make.
Can I just make a comment on that? I've been trying
Yeah.
Brain HQ. You can try daily free, but there's only one module in there that you take brain tests under that they're recommending for preventing dementia. But anyway, it's more extensive than just that one training, but it is free and you get to do a test every day, like for free. But I just wanted to mention that to people if they want.
And it's free. And
it's free for one test one day.
Right.
If you want to do more, you have to
pay. But it's side effect free. I don't think there's any side effects to that. And so again, if it's relatively cost effective, if it's side effect free, go for it. I mean, again, maybe I'm going to look into it too, because I want to keep my brain as sharp as possible in addition to learning languages. But again, at the end of the day, and realistically, again, not to downplay that, we don't really have medicines that do that. And so again, when I don't have medicines that do these things, I am always open to finding these other ways to try to help people do better, because again, we can only do so much. And if that's going to help, I'm all for it. And with that, I guess we'll wrap it up. Casey, I'll send it back to you. Thank you all for listening. And as I always say, as long as somebody has a question, I will keep coming back and doing this every month. If we ever come and nobody has a question, that's when I'll throw in the towel and call it a day.
Thank you, everybody. And thank you, Dr. Leichliter. That's a wrap for June. Stay tuned for July's Talk with the Doc.
Go enjoy the weather, guys. Have a good night.